පටන් ගමු නේද එහෙමින් කට්ටිය.
පටන් ගමු සර් කට්ටිය join වෙන්න.
හරි. Okay. Right. So let's go to the second question paper of a total of 3. And these questions are focused on infections of the respiratory system, right? And within this, there was obviously a large content of subject matter that we have to cover. But the good thing is, sort of, most of these questions are quite straightforward, and you don't need to worry too much about it. Harry. Okay. Right. So let's start with pneumonia. Now, I'm sure all of you are familiar with this classification. This is a clinical classification of pneumonia. And you can see that the main idea of this clinical classification is that it is useful because you can make a rough guess as to what organism is involved, right? And then based on that, you can decide on what antibiotics to give, right? Or what treatment to initiate. So that's the most useful part of this sort of classification of pneumonia, right? Now, this is very important. This may seem like sort of boring, just memorizing stuff, but there are going to be a few questions on, so what sort of organism is common in hospital-acquired pneumonia? What sort of organism is common in community-acquired pneumonia, and so on. So you need to have a rough idea of what organisms are common in each type. Of course, in hospital-acquired pneumonia, you see quite a lot of gram-negative organisms, right? Pseudomonas, and also a large amount of sort of drug-resistant organisms, including MRSA, which can cause pneumonia. Right, so that's a clinical classification of pneumonia. Right, so the first question focuses on community-acquired pneumonia. Right? So specifically, we're asking about community-acquired pneumonia. First one, Streptococcus pneumoniae is the commonest bacterial pathogen causing community-acquired pneumonia, right? That is true. Epidemiologically, that is what we find. Right. Now, when you take pneumonia in patients with cardiopulmonary disease, right? It's quite important to say that cardiopulmonary, so heart failure, especially patients with COPD, right? Have an excess of Haemophilus influenza infection as well as pseudomonal infection. Now, it's important to remember because these are MCQ, all of these are MCQ points. Pseudomonas infection is particularly troublesome in patients with COPD and bronchiectasis. So please keep an eye out on that, right? And in patients who take a lot of alcohol, they have a risk of aspiration pneumonia. So they have anaerobes, Klebsiella, which can cause pneumonia as well. All right. So the second statement, Haemophilus influenza can cause community-acquired pneumonia in patients with cardiopulmonary disease. That's right. Especially COPD bronchiectasis, you see quite a large excess of pseudomonal infections as well, which also can appear as an MCQ. Right. Saranga, you want to ask a question? No? Okay. All right. Hi. Right. Pneumonia and Klebsiella is associated with pulmonary cavitation. Now, that's another important MCQ point. There are certain infections that can cause cavitating pneumonias. Sorry, cavitating pneumonias. Of course, TB is at the top of the list, but there are certain other organisms that can cause cavitating pneumonia. Now, in one of these slides, I'm sure I have given you a list of all the causes of cavitating lung lesions, right? But I want you to particularly remember these fellows, right? Number one, Klebsiella, right? So that can cause well-known cause of cavitating pneumonia. Burkholderia or melioidosis causing organisms, well known to cause cavitating pneumonias and also lung abscesses, right? Another fellow which can cause cavitating pneumonia is Staph aureus. So please remember that as well. So remember Staph aureus, Klebsiella, melioidosis, right? And also if you are really particular about it, there are filamentous bacteria like Nocardia, which can also cause cavitating pneumonias. Right? So, you have MCQ points. These are boring microbiological details, but you will get one or two statements on these things, I'm sure. Right. Okay, but you can see there are lots of other causes of cavitating lung lesions as well. Right. So that is important to appreciate. Hari. Eka hari. That is true. Right. The next statement is E. coli is a common cause of community-acquired pneumonia is false. So you see this gram-negative pathogen involvement mostly hospital-acquired pneumonia, right? That is where you see the E. coli coming in quite a lot. Enterobacteria, enterococci. All these gram-negative fellows cause infection in hospitals, not in communities, right? Right. So that's wrong. Right. Now, influenza A is a viral infection. There's a major outbreak of influenza A in Sri Lanka as well. In the UK, obviously, you get influenza at this time of the every year. But in Sri Lanka also, there is a rise in the case of influenza A, as you might have heard. The problem with influenza A is most people, it just causes a flu-like illness and some sort of chest infiltration. But mostly it is a sort of flu-like illness. You feel horrible during the episode, but it spontaneously resolves. Now, the important problem with influenza A is that it can cause a sort of post-influenza staph infection, which is quite nasty, right? So a post-influenza staph aureus infection is well known and has a high mortality, right? So, but most of the time it's a self-limiting illness. The secondary superadded bacterial infection with staph aureus is particularly troublesome in some people. So that is correct as well. Right. So from this MCQ, the whole idea was to introduce you to etiology. So you should have an idea of what organisms cause each clinical type, right? And also there are special things like in structural lung disease, COPD, bronchiectasis, the excess of Pseudomonas. So those things can appear as MCQs, right? And also cause of cavitating pneumonias. The ones that I told are important, right? Any questions about that MCQ? Right, that's just microbiology, nothing much there. Right, now if you take clinical syndromes of pneumonia, I'm sure you would have heard of this term, typical atypical pneumonia, right? So typical pneumonia, atypical pneumonia. Now you have to understand that the word typical atypical is mostly based on the pathogenesis of the pneumonia, right? It's not really on the organism only, right? It is actually based on the pathogenesis of the pneumonia, right? And if Panduka sir has done a lecture on this, he would have definitely told you about this. So typical pneumonia, the involvement is mainly alveolar, right? So it causes alveolar inflammation, alveolar consolidation. That is what you see in a typical pneumonia, right? In an atypical pneumonia, the infection is mostly interstitial, right? So this is in between the alveolar spaces. So pathologically, that is the main sort of differentiation between the two. So typical, you have alveolar consolidation, alveolar inflammation, there is exudate within the alveolar space. But in atypical pneumonia, it is mostly an interstitial sort of inflammation and infection that takes place. Of course, the organisms are different as well, right? Typical pneumonia is mostly strep pneumonia driven. Whereas atypical pneumonia, you hear organisms like Legionella, Mycoplasma, Chlamydia. Right. So true or false regarding atypical pneumonia can be due to infection with Legionella, like Harini. That is true. Also Mycoplasma, Chlamydia, all of these can cause atypical pneumonia. Now, an important consequence of the fact that atypical pneumonia is interstitial, so they don't present with the classical pneumonia signs and symptoms because they're interstitial, not alveolar. Sort of cough, sputum, that sort of thing is unusual in atypical pneumonia. But I think they can present without any of those symptoms. And also when you listen to their lungs, you're not going to find much signs because it's everywhere interstitial. So they have a sort of bilateral, patchy sort of involvement rather than a clear-cut lobar consolidation. Right? Because it's interstitial. That clinical presentation doesn't fulfill the usual cough, sputum, fever, and their X-ray radiology is also interstitial, widespread, patchy involvement. Auscultation, you don't hear anything much at all, right? Because again, it is interstitial and not alveolar, so you don't find any features of consolidation. You might hear a few crackles here and there, but nothing else. So going back to the MCQ, prominent physical signs with minimal chest X-ray infiltrates is a feature kineka varadi. Okay, anit patta tamai enni, right? So you will see extensive patchy interstitial involvement on chest X-ray and minimal physical signs. Right? Auscultation, you might hear a few crackles here and there, but nothing more. Right. In atypical pneumonia, it's not very common to get significant neutrophil leukocytosis. They can get lymphocytosis in the pulong, or maybe just a slight rise in the neutrophil count. You don't see, if you see a true step pneumonia, consolidation pneumonia, the white cell counts are 30,000, 25,000, or even higher. But in atypical pneumonias due to Legionella, mycoplasma, you will see maybe the white count is not high. You might feel a little bit of a lymphocytosis, right? And then you might see some other changes as well. Now, as you know, the atypical pneumonia causing organisms are difficult to isolate, right? They cannot be cultured or stained most of the time. And you have to do special tests like serological tests to diagnose them. An important thing about Legionella is that you can look at the Legionella antigen in the urine. That is a bit special about it. It's not the organism, it's the antigen that you can find in the urine.
So is the second one true?
The atypical pneumonia true nasal form. Very. Right? So organism is isolated on sputum microscopy. You have to either check for Legionella specifically, the urinary Legionella antigen, or in certain cases like mycoplasma, we go by the antibody responses. And of course, the clinical manifestations. In atypical pneumonias, you get extra pulmonary manifestations. One of the commonest extrapulmonary manifestations is a hemolytic anemia, a cold autoimmune hemolytic anemia that you get in mycoplasma infection. Also, Legionella, you get a very prominent hyponatremia, right? Very prominent hyponatremia as well. So, and of course, you know that mycoplasma can cause Guillain-Barré and various other neurological syndromes as well, right? Post-neurological syndromes. So these are all extrapulmonary manifestations. Okay. And of course, atypical pneumonias. Yes, Sasidu, Legionella can cause diarrhea. Yes, that's right. Hyponatremia, diarrhea, pneumonia are some of the common manifestations of Legionella. Okay. Right. Which may come to your question. Just give me a second. Then penicillin group of antibiotics are used as first-line treatment. For atypical pneumonia, we use things like doxycycline, clarithromycin, to cover these organisms. Okay. Now, Vismi is asking about what is bronchopneumonia. So, we say bronchopneumonia, lobar pneumonia are more sort of radiological or histological sort of classifications. How is it? You can't specifically say, you can say that, yes, step pneumonia mainly causes a consolidation, a lobar pneumonia. But bronchopneumonia, various organisms can cause it, right? These fellows cause a more of an interstitial pneumonia. These atypical pneumonias are an interstitial pneumonia, right? Hari. Hari. So on the right you can see, left you can see a clear consolidation. This is sort of pattern you get a step pneumonia, වගේ දේවල් වලට, right? Whereas in an atypical pneumonia, it will be sort of more diffuse, patchy involvement, like you see on the chest X-ray in the right. Right. These are also some important things about Legionella, which might appear in MCQs. We have discussed most of them, right? And we've already discussed that gastrointestinal diarrhea. Sasidu asked that, gastrointestinal symptoms like diarrhea you can get. And remember that this Legionella is a nice epidemiological story as well, right? These infected aerosols are how the organism spreads. So you see these in our AC environment. Okay? The questions usually are hotel, like a patient was in a hotel or went on holiday sort of story, you will find in the MCQs, right? Sorry. So a few facts about Legionella for you to read, and we already discussed most of these things. Naveen asked erythromycin. That's slightly gone out of fashion for atypical pneumonia. You can use it, but now we tend mostly to use either doxy or clarithromycin. Right? Chest X-ray in COVID pneumonia is essentially there is a lot of peripheral involvement. So it's again a patchy sort of involvement, but mostly peripheral predominant. Right? Middle and upper zone peripheral predominant pattern in COVID. Right. Now, just for your reading, these are all sort of possible extrapulmonary manifestations in the atypical pneumonias. So, just for you to read. That is the summary of the statement in atypical pneumonia. These are all sort of extra pulmonary manifestations that you can get. Any damn thing is right. Just a glance through that list. And I've sent you these presentations, so just have a look at these before you go for the exam. Oh, අහලා තියෙන එක එක කාලවලදී myocarditis වෙනවද, pericarditis වෙනවද, ඔය එක එක ඒවා අහලා තියෙනවා. Right. Okay, fine. Right. Now we go to question number 3. Any questions on question number 2? So there we explored the difference between a typical pneumonia, atypical pneumonia, that is mostly based on the actual pathology that takes place in the lungs. Of course, there are organisms that cause atypical pneumonia, like Mycoplasma legionella. Hi. So respiratory fluoroquinolones can things like levofloxacin, right? That is the most commonly used drug. Hi. Now the third question, again, we are talking about the first two statements we have already discussed. So I told you that one of the common extrapulmonary manifestations of mycoplasma is cold agglutination. So that is, or cold autoimmune hemolytic anemia. Hyponatremia is a common feature of Legionella, is also true. Hari. Now, one important problem that you get in pneumonia is that they can get effusions, pleural effusions, right? And some of these pleural effusions can transform into empyemas, right? Which we'll talk about in a minute, right? But you don't need to aspirate all effusions that occur in pneumonia, right? It's only specifically when you think of an empyema that you should aspirate it, right? So, eka paradi. Right. Now, the last two statements in this question focus on the prognostic markers of pneumonia, or the markers that indicate severity in pneumonia. Now, of course, you have to know the curve 65. Curve 65, that is an important sort of prognostic marker of pneumonia. And this is mostly for community acquired. We use this for community acquired pneumonia. But there are other scores like the pneumonia severity index, right? which are also severity scores, right? So ඒක නිකන් again common sense things තමයි ඔක තියෙන්නේ. මේක ඔක්කොම කටපාඩමින් මතක තියාගන්න අමාරුයි. But common sense things තමයි තියෙන්නේ, right? So for example, comorbidities, right? And also things like acidic arterial pH, right? Presence of high blood urea nitrogen, right? ඒ වගේ දේවල් තමයි උකට ඇතුළත් වෙනවා කටපාඩමින් දැනගන්න ඕනේ නැහැ. හරි කටපාඩමින් දැනගන්න ඕනේ නැහැ. It is well known also that there are certain groups of patients who require ICU admission, right? So now these severity scores, what they do is they sort of, one, they classify the prognosis and also they tell you how intensively to treat the patient. So if your pneumonia severity is low, you can give oral antibiotics and send the person home. If your curb 65 or PSI is high, then the patient needs admission, right? And most often intravenous antibiotics, right? Most often intravenous antibiotics. Now this slide shows you what are the indications for admitting a patient to ICU, right? What are the indications to admit a patient to ICU? Of course, if they are in respiratory distress, you need to take them into ICU, intubate and ventilate them. There is no doubt about that. හැබැයි මෙන්න මේකේ so anything unstable, respiratory distress, these are common sense things. හරි. හැබැයි you need to also consider ICU admission for people who have very severe multilobar pneumonias. Also මෙතන අමුතු එකක් ඔයගොල්ලෝ දකිනවා මේ leukopenia, right? Leukopenia. Now usually patients with pneumonia will have a high white count, right? With severe pneumonia, they will have a high white count. In a severe pneumonia, if they have low white count, that is a very dangerous feature. Right? That means that they are not mounting an adequate inflammatory or immune response. So actually, leukopenia is very dangerous in a patient with pneumonia. Right. So common sense, common things, right? Like an unstable patient, a patient in respiratory distress, patient with multilobar pneumonia, right? Low white count. එක ස්පෙෂල් දෙයක් ඒ අතර ඉගෙන ගන්න ඕනේ. So arterial pH of less than 7.2, poor prognosis, හරි. So this is acidosis, is a poor prognostic marker. And leukopenia with a WBC count of less than 4,000 is predictive of the need of ICU admission is also true. So remember those අමුතු දේවල් ටිකක් leukopenia, thrombocytopenia, significant thrombocytopenia. These all indicate very severe infections, right? Very severe infections, right? Of course, if they are in respiratory distress or they have hypotension, they should be considered for ICU admission. But also remember these other things that I have mentioned. Right.
Sir, criteria ke pH එක මේ they haven't mentioned.
මෙතන නෑ, it's not a sort of ICU admission, but it does indicate a poor prognosis. Yes. Hari?
Okay, sir. Thank you.
Right. Hi. So those are about severity scores and prognostic indicators for community-acquired pneumonia. If your severity score is low, potentially a patient can be discharged and treated with oral antibiotics. But if your severity score is high, the patient needs admission and most often intravenous antibiotics. And there are some markers that if the patient has any of those markers, the patient might need ICU admission. Hari. The make a best response MCQ essentially this is a patient who has a pneumonia and now has a pleural effusion. Neither. Now the important point here, this is the sort of patient where you suspect an empyema. Ari, patient is getting worse, right? Fever again, right? And also there are there is a pleural effusion. This is the sort of patient where you consider very strongly the possibility of an empyema. So let's talk a little bit about empyema and then come to the answer for this question. Right. Now, what are the features of an empyema? Number one, when you aspirate them, they will have frank pus. So feature number one, when you aspirate them, you get a pus. Feature number two, if you stain their pleural fluid, it will be positive gram stain and culture. Because in empyema, there is direct invasion of the pleural space by the bacteria. So from the lung, now the bacteria is entering the pleural space in an empyema. So therefore, they will have pus in the pleural space, and also when you stain their pleural fluid, they will have a positive gram stain and culture. Also, bacteria are rapidly multiplying within the pleural cavity, in the pleural fluid. They are multiplying inside that. So what happens? They are using a lot of glucose. So the glucose will be low, and the pH is less than 7.2. The pH of the pleural fluid is less than 7.2. So pus, positive gram stain, pH less than 7.2, glucose less than 60. In addition, empyema, if you scan the chest, ultrasound scan, you see thickened, septated pleural cavity. So the pleura will be thickened and there will be septations within the pleural cavity. So all these features suggest an empyema. Right? So the pus, the gram stain, the pH, glucose, and the thickening and septation of the pleura. These can indicate an empyema. Right. Okay. If there is a suspicion of an empyema, you need to aspirate the pleural fluid and send it off for all those investigations. And if you confirm an empyema, the treatment is an insertion of an IC tube. Right. That is the most reasonable thing to do. If there is a suspicion of an empyema, insert an IC tube. Right. Aspirate karala. IC tube. So what are the features again? The ultrasound might show suggestive evidence, right? If you aspirate it, pus enna puluwan, right? The pH, the gram stain එක පොඩ්ඩ වෙලාවකින් කරගන්න පුළුවන්, right? Culture takes time, but the gram stain you can do. And because the bacteria actively multiplying, they use up the glucose as well, right? So complete drainage is very important if they fulfill these criteria. All right. Any questions about that?
Sir, when they say next appropriate investigation, is it diagnostic pleural fluid or blood culture?
Metanada?
Yes.
Yeah. So in this, it has to be diagnostic pleural fluid because you are focusing on an empyema. So that has to be the most next. Blood cultures will not grow anything. It is the pleura that you need to tap. So it is a diagnostic pleural. That's the most. Right. So do you insert an IC tube on suspicion or after confirmation of pleural fluid analysis? It depends on the person who is managing the patient and also how sick the patient is. But I would say for you, yeah, better say on confirmation. But somehow suspicion ultrasound you find a lot of septation and the patient is getting worse. Then what you do is you do the ultrasound scan, take some fluid and put the tube at the same time because most of these IC tubes are ultrasound guided. So it depends, but yeah. Of course, better if you confirm it and put it in, but sometimes you put it in on an empirical sort of suspicion basis as well. Rehani, blood stain sputum can occur in empyema. It's not specific to empyema, but can occur. Hi. Good question. Thank you. Good questions. Thank you. Hi. So that is all about pneumonia. Any questions in general? Hi. Oh, boy.
Excuse
Right.
me, sir. Do we do the ultrasound scan first and do the pleural fluid aspiration, or
Oh, මෙහෙමයි. දැන් ඔයගොල්ලෝ වාට්ටුවේ පුරුදු වෙලා තියෙන්නේ, or at least I don't know what they've told you, but blindly නේ කරන්නේ. Nowadays we don't recommend that, right? Because of the risk of pneumothorax. So currently the standard of care is, if you are doing a pleural fluid aspirate, it has to always be under ultrasound guidance. Hi, the Panchali. So that question doesn't arise. ඔයගොල්ලෝ වාට්ටුවේ මන් දැන දැකලා තියෙනවා ඔක blindly ගන්නවා කියලා. Blindly ගන්න එක දැන් recommend කරන්නේ නැහැ. Hariද? You have to do it under ultrasound because it's much more safe. And all wards have an ultrasound scan. Accessibility එක තියෙනවා. ඒ නිසා there is no කිසිම සමාවක් නැහැ වාට්ටුවේ blindly කරන එක. Right? So then that question doesn't arise, Panchali, because you will anyway be doing the ultrasound scan. Hari?
Okay.
Hari. ඊට පස්සේ තව කතන්දර වර්ගයක් අහලා තියෙනවා. So pneumonic effusion is just a name given for the effusion occurring with so acute pneumonia පටන් ගත්තු ගමන්ම you can get a bit of a effusion as a reaction to the pneumonia. Then two people have asked septations තියෙනවා IC tube දාන්න පුළුවන්ද? පුළුවන්, but it's very difficult. Hari? Very difficult. Sometimes එක එක වෙන වෙන techniques උත් තියෙනවා. There are lots of septations, you can break it. Thoracoscope එකක් දාලා කඩන්න පුළුවන් එක එක කතන්දර තියෙනවා. Hari. But those are a bit too much for you. Supun Halter, can you differentiate bronchopneumonia, lobar pneumonia examination? Very difficult, right? Yeah. So lots of people have asked about this flocculation story. It is difficult to drain, but if you place it carefully under ultrasound guidance, you can put it in a nice pocket where you can drain it off. If it doesn't drain, you'll have to do a thoracoscopy and break the loculations and take the fluid out. Right? But take a part of it, you will be able to know the key. Right. Okay, good. Nabil.
Yeah, with regards to that earlier explanations, if you're doing the ultrasound scan anyways with fluid samplings, in this BR, the answer would it be ultrasound scan or diagnostic pleural aspiration?
When we say diagnostic pleural sampling, we imply that it is ultrasound guided because we don't do it in other ways anymore. It is not recommended to be done in any other way. Okay.
Thank you.
Right. We'll talk about LDH and pleural effusions on the next day, hopefully on Saturday, because there's a whole paper on pleural effusions. So we will talk about it. Yes, LDH is increased in empyema visha, but it is not specific. It can go up in any sort of exudative effusion. It's not specific for empyema. Empyema කියනනම් pus තියෙන්න ඕනේ, gram stain, pH, all these criteria we take into account. Right? Right. Okay. Fine. Right. Now we go to another type of infection in the lung, which is a lung abscess. Right. Again, in your clinical appointments, we did the OSCE classes. I showed you what a lung abscess looks like. So it is a cavity with a fluid level. And most often this cavity is thick-walled. Right. This is thick-walled. Right. Thick-walled cavity with a fluid level. And on the left of the screen, I have given you the sort of causes of lung abscesses. Now, the important thing to remember is that a lung abscess, there will be a mixture of organisms, right? It is very difficult to isolate a single organism in a lung abscess. It will be a mixture of organisms. And this will be anaerobes, aerobes, right? Mix එකක් තමයි. And in this list, you can see that it is most of the time either anaerobes or mixed aerobes and anaerobes. So it will be a mixture of organisms that you see. Hari. So true or false regarding lung abscess? It is mostly due to pseudomonal infection and නෙවෙයි ළමයි. As I told you just a minute ago, it is mostly due to Pseudomonas can cause lung abscesses. But as I told you a minute ago, it is very difficult to implicate a single bacteria. Most of the time, lung abscesses, there will be aerobes, anaerobes, and a mixture of bacteria inside. So that is wrong. Lung abscess due to recurrent aspiration is not common in this species anatomy, neither. So it is lower lobe superior segment or something. Please revise your anatomy. Right side decay, lower lobe superior segment, if I remember correctly. Okay. Ooh, sorry. Now, there are several important causes of multiple lung abscesses. So let's talk about that now. Multiple lung abscesses. Now, multiple lung abscesses can occur in patients with melioidosis. That is a very famous cause of multiple lung abscesses. A close second is the patient who has right-sided endocarditis. So the moment you see multiple lung abscesses, I think I showed you a nice X-ray of this in your appointment, right? Multiple lung abscesses, melioidosis, or the other one is right-sided endocarditis. Because in right-sided endocarditis, the vegetation on the right heart breaks away into the lungs, causing multiple abscesses. And you can link up the multiple lung abscesses with IV drug users because they get a lot of right-sided endocarditis. Right. So on X-ray, I told you that lung abscesses are usually thick-walled. Thin-walled cavities වගේවා එන්නේ ගොඩක් කරාට මේ autoimmune etiology. Say for example, something like vaginous granulomatosis, right? You can get thin-walled cavities, right? So in lung abscess, typically it's a thick-walled cavity and an abscess that you get, right? Sorry, right. Now, because there are multiple types of bacteria in a lung abscess, these are very difficult to treat, right? And often you have to give them aerobic and anaerobic cover both. So we often give something like cefotaxime and metronidazole or something like that, right? And the problem with this is also because the lung abscess is very deep and there is a thick wall, thick wall. It's very difficult for the antibiotics to get in also. So they need long courses, 6 weeks minimum, I would say, right, of antibiotics, right? Long courses of antibiotics. සමහරලාට ඒක වැඩ කරන්නෙත් නෑ. You need to surgically remove them, drain them also in some people. So the summary of the story is there are multiple organisms inside, difficult to treat, long courses of antibiotics. 6 weeks minimum, and they often need surgery to take it off as well. So short courses කියන එක වැරදි. Right. Any questions about lung abscesses? So pneumatocele is a different thing. Pneumatocele is a thin-walled. It's not classified as a cavity really. Right? Can use clindamycin to treat abscesses? Yes, clindamycin also has a very good anaerobic cover and a gram-negative cover. So yes, we use clindamycin also. Rehani. Young children, upper loads. That I do not know. Ek poda balan pediatric potthara diyana. Hi. Okay. So if everybody is happy, we will move on to bronchiectasis. Right. Now this is a very typical appearance of bronchiectasis on a CT scan. You can see all these dilated airways. So you can see the dilated airways right up to the edge of the lung. Right. Which is very typical of bronchiectasis. Right. Right. And you can see this arrow occur, which is called a signet ring appearance. That's called a signet ring appearance. Right. Signet ring appearance. Right. So you can see these dilated air passages. The signet ring. Right. There's a signet ring there also. So you can see dilated air passages, signet ring shadows as well. You can see extensive bronchiectasis in the X-ray as well. Oh, Chaman.
So you said using surgery to drain the abscess. What about postural drainage, sir?
If the abscess is opening up into a bronchus, that's not always the case. If the abscess is opening up into a bronchus, then you might be able to drain it out posturally.
Okay.
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 Okay. So this is bronchiectasis, and let's talk about bronchiectasis in the MCQ there. Hari. Now, මෙතන මේ slide එකේ මම ඔයගොල්ලන්ට මම කරේ මේවා ටික notes විදියට ඔයගොල්ලෝ තියාගන්න last few weeks of revision. Just quickly go through these. And I've sort of made these based on sort of things we like to ask in MCQs. Now, actually, Mama, I'm strongly against these true-false MCQs, and I hope that we will stop giving them in the near future because they are just recall. And obviously, the whole world has moved away from true-false MCQs now when they are using best response MCQs. They are more clinically oriented. But unfortunately, because you have true-false MCQs, me wage wahano. So, etiology of bronchiectasis, what we see most of the time, especially in our countries, secondary to prior infection. So, previous infection-related bronchiectasis is what we commonly see, etiology-wise. So, things like post-TB bronchiectasis, NTM here stands for non-tuberculous mycobacteria. So, post-NTM bronchiectasis. And sometimes they have very severe pertussis or measles in childhood. They get bronchiectasis. So, large majority of our patients with bronchiectasis are due to this sort of prior infection. However, you get patients who have congenital bronchiectasis, patients who have various problems in clearing secretions like cystic fibrosis or cartilaginous syndrome, right? Patients with immunodeficiency, especially immunoglobulin deficiency, they get bronchiectasis. So mainly remember that most is post-infection, post-TB bronchiectasis. And also you sometimes see patients with congenital bronchiectasis, secretion clearance abnormalities, immunodeficiencies also presenting with bronchiectasis. Hari. You can get localized bronchiectasis in things like tumors, වගේ දේවල් වලට එන්න පුළුවන්. හරි. Okay. මෙතන මේ COPD එකක් තියෙනවා. ඒක නම් I don't agree with එක කපලා දාන්න ඒක. අදාළත්. හරි. So yes, so cause of bronchiectasis මේවා තමයි කතා කරන්නේ. And also some etiologies have certain areas that they like to affect. For example, things like TB, cystic fibrosis, mainly upper zone bronchiectasis, right? And secondary to non-tuberculous mycobacteria is mostly right middle zone, right? We talked about allergic bronchopulmonary aspergillosis as a cause of asthma exacerbation, right? And that is a cause of central bronchiectasis, close to the hilum, that is causes the bronchiectasis. So these are just theoretical things, katapadan things, but unfortunately, a true-false MCQ, right? So the anatomical localization of various etiologies. Right. So bronchiectasis due to non-tuberculous mycobacteria, I've said it involves the right middle lobe, right middle zone, upper lobe. Mycobacterium TB, yes, but not non-tuberculous mycobacteria classically causes this right middle lobe bronchiectasis. Don't ask me why. Now, when we are talking about pneumonia, I told you that patients with structural lung disease have a higher incidence of pseudomonal infection. And the problem with patients with bronchiectasis is that they are often colonized with pseudomonas, right? And this colonizer can frequently cause infection, right? Colonizer shape and then when the immunity dips, they get infected, right? So these are sort of opportunistic colonizers. So they get recurrent pseudomonal infection. They are very difficult to treat. They are drug resistant most of the time. Hari amaru, right? So presence of pseudomonas sputum, yes, is a poor prognostic feature. Airflow. So how do these patients with bronchiectasis present? They come with the cough, the copious sputum. You are very familiar with that type of presentation, the cough, the copious sputum production. But they do also have airflow obstruction features. And sometimes we treat them with inhalers, right? That might help symptomatically. Right. I've already told you that the diagnosis of bronchiectasis is obviously with CT scans. Sometimes you might see it on the chest X-ray, but important to remember that the gold standard of diagnosis, the gold standard, the most important mode of diagnosis is with a CT scan and not a chest X-ray. The gold standard is CT. So do you see all these things like I showed you, the signet ring and the dilated airways? Right. Sputum culture is not essential for diagnosis. That's wrong. But we always recommend a sputum culture before starting antibiotics. That is always recommended, right? Because of the fact that they get a lot of pseudomonal infections, you need to diagnose it. Of course, you start empirical antibiotics and take a sputum out first, right? And there is plenty of sputum that these patients produce. And when it comes back, you have to look at, see if it's pseudomonas. These are commonly drug resistant. So change karanna puluwan antibiotics. Right. One of the mainstays of managing bronchiectasis, the main ways which you manage bronchiectasis is with postural drainage. Now, Chamath asked about postural drainage in lung abscesses. In bronchiectasis, definitely postural drainage is a very, very important part of the management. So, sputum ටික එළියට ඇදලා දාන්න පුළුවන් නම් by postural drainage, that helps a lot. Prevents infection. Right. Of course, if they get infected, then you have to start antibiotics. Keep in mind that there can be pseudomonal infections. So, you have to make a clinical judgment as to starting them on anti-pseudomonal antibiotics like ceftazidime. Some people use nebulized antibiotics also. Unfortunately, hariyata me antibiotic nebulized kind machines we don't have in Sri Lanka. I'm sure they have them in Balisara, but they are not seen in common walls. So, the samanya nebulizer you need a special type of nebulizer for that. But if you can, they are good because they deliver the antibiotics directly to the lungs. So, are used in the management kineka hari. Right, so this is about, so we've gone through the etiology of bronchiectasis and some concepts about clinical presentation and also management. Any questions? So make up a cutting keyword. So these are the most important principles of management. And some people, we do give them prophylactic antibiotics. So Ashpa, the airflow obstruction is because of all the reasons that you have mentioned in your question. Could be due to bronchospasms, can be structural related. There are multiple things that predispose. Tisura.
Sir, bronchiectasis, are the antibiotics given just in that acute exacerbation or are they given long term?
So depends. Some people who have recurrent exacerbations, we do give prophylactic antibiotics. But of course, the risk of that is that they can develop resistance. Right? But of course, if they have ICU admissions, recurrent infections, hospital admissions, sometimes we give prophylactic antibiotics. And azithromycin is the common agent that we use.
Right. And also, sir, what's this pulmonary rehab they use?
Oh, pulmonary rehab is a very broad term. Eka pulmonary rehab kiyanne, essentially what they do is a series of behavioral exercise-related interventions that improve exercise tolerance. So it's physiotherapy, exercise training, sort of upper body strengthening because they can use some of those muscles to breathe. So it's a sort of it's a collection of things, interventions.
Right. Thank you.
Hi. Okay. Any other questions? So Hari. Kanishka, nebulization superior, I will not really, but they can be a good adjunct. Nebulized antibiotics. ලංකාවේ නෝක හරියට කරන්න බෑ. Kusala bronchiectasis can present with massive hemoptysis. That's right. Because sometimes what can happen is the dilated when you get bronchiectasis, the air passages dilate, and sometimes this can erode into a bronchial artery. Right. Somebody infection where it weakens the bronchial wall and it infiltrates into a bronchial artery, and that can cause massive hemoptysis. The CT that we use to diagnose, yes, it is the HRCT, high resolution CT scan. Answer, no, mycoplasma is not a common cause of an infective excess. It can cause infective excess, but it's not a common cause. Godak kiyadene hemophilus influenza, මොනවාද pseudomonas වගේ දේවල්, pneumococcus, right? These are the common triggers for infective exacerbation. Right. Okay. Now then we move into tuberculosis. Now I'm really not going to go through the sort of right. So Chamatka, this story of traction bronchiectasis is different. Right. So you don't need to manage traction bronchiectasis. So traction bronchiectasis occurs in interstitial lung disease. It doesn't have the same pathogenesis or the requirement for management as actual bronchiectasis. It's just the airways are a bit dilated. They can get infections, but the pathogenesis is different. So it's just a consequence of ILD that you get traction bronchiectasis. It's not a specific management problem or issue, right? Right. So I won't go through the sort of TB pathogenesis, but you know that there is a primary form of the TB infection, which is the initial exposure to the organism, where you get this Ghon's focus and Ghon's complex. And then you know that you have a secondary tuberculosis or post-primary tuberculosis, which is an exaggerated immune response to the organism, where you get cavitation and fibrosis. Right. Of course, if the immune system is not good, patients with TB exposure can have disseminated infection, right? As well. So patients with HIV have a higher incidence of disseminated TB infection. Their TB is not in the lungs, it is in the organs. That is the problem. Right. And we'll come back to that concept in a little while as well. Right. So this first MCQ is on primary pulmonary TB. Hari. The first ඉංග්‍රීසි වැරදි primary pulmonary TB, the majority presents with a prolonged febrile කියලා හදාගන්න. ඒක නිකන් අමුතු විදිහට තියෙන අර මොකද්ද? Yeah, so it is not properly, the grammar is wrong, right? Right. So presents with a prolonged febrile illness. ඒක වැරදි. Primary pulmonary TB is mostly asymptomatic, right? Mostly asymptomatic. සමහර වෙලාවට you can get a little bit of a febrile illness, and they can get erythema nodosum, right? So clinical manifestation තියෙන පුළුවන්. They can get erythema nodosum. Some people get a very, very small pleural effusion, right? So erythema nodosum වෙන්න පුළුවන්. Small pleural effusion. And you get this very unusual nodular conjunctivitis, phyllectenular conjunctivitis. I'm sure you would have heard this in pediatrics. Right? It's very odd nodular conjunctivitis. Phyllectenular conjunctivitis. It's a recognized feature. It is not a common feature, but it is recognized. Right. And you can get a small pleural effusion as well. Right. Okay. The third point is causes caseation within the regional lymph nodes. Now that's again, yeah. Excessive caseation, you can get a little bit of caseation anyway. What I was actually meaning to ask is in primary TB, you don't get prominent or excessive caseation. You can get a little bit of caseous necrosis, not a lot. So excessive Right? Make a වැරදි, make a hari, make a excessive කියලා හදාගෙන මේව කරගන්න. Right. Causes a pleural effusion with a positive MAN2 test, right? Possible, right? Small pleural effusion එකක් එන්න පුළුවන්. And erythema nodosum is associated කියන එක හරි. Right. Any questions about this one?
So is MAN2 positive in the first group?
When in primary TB, you can get a positive MAN2, but it's mostly in secondary when you have an established immune response, but you can get a positive MAN2 even in primary TB. Yes. It takes a few weeks for the response to mount. සති දෙකක් විතර වගේ යන්න පුළුවන්. Yeah.
Right. Thank you.
Yeah. Right. So this is a sort of a comparison between primary TB and post-primary TB. So in post-primary TB, it is a very important thing to remember that this is an exaggerated immune response against these organisms that persist and replicate, right? That is, yeah. Right. Right. So now from this point onwards, your focus is on So Hirani Rasi, when you say presence, it should be, yes, you should consider asymptomatic people as well. Yes. Yeah. So, yeah. So you can argue that it's not, but that's the usual meaning. So when you say, yeah, in the majority presence scale, yeah. Right. Okay. So true false regarding pulmonary TB. Now here from this point onwards, our focus is on post-primary TB. A negative MAN2 excludes the diagnosis. Now what is this MAN2 test? So how do you diagnose TB? We all talk about the MAN2 test, but remember the MAN2 test is not diagnostic for TB. A positive MAN2 does not diagnose active TB, does not diagnose active TB. The only thing the positive MAN2 does is, it sort of says, okay, there is an immune response against TB. That is the only thing it says, right? So, yeah. And remember, people with HIV, even though they have overwhelming tuberculosis, their MAN2 can still be negative, right? That's an important MCQ point. Because their immune system is knocked off, they don't mount a MAN2 response, HIV patients. So even though HIV patients have full-blown TB, they might still be negative, MAN2 negative. Hi. So it is not diagnostic. Right. Now we talked about this HIV story. In HIV, because the immune system is weak, they have a lot of disseminated infection. So the TB is not in the lungs, it is everywhere else, right? So in HIV, they have disseminated TB. Lung එකේ නෑ හැම තැනම ගිහිල්ලා, right? So it disseminates from the lung everywhere. So actually, studies have shown that if you take their sputum or culture, the chance of you isolating an organism is lower. Because the organism is not in the lungs, it is everywhere else, right? So that is a special thing. But sputum culture and AFB is very useful for diagnosing TB, as you know. But in HIV, the problem is that the organism has gone from the lungs into other organs. So sometimes it can be difficult to diagnose with a sputum AFB or culture. ඒක මතක තියාගන්න. හරි. Now a little word about cultures for AFB. Now you know that this standard Lowenstein-Jensen culture medium, LJ medium, that is a standard culture medium that we use. That takes about 4 to 6 weeks to come back. But now we use a lot of liquid-based cultures that are that give back results quicker, right? So the liquid-based cultures, you can be positive in about 1 to 2 weeks. So that's much quicker than the standard Lowenstein-Jensen culture medium. Right. So when you are diagnosing TB, then MAN2 test is useless, right? It doesn't diagnose TB, it just tells you there's a TB immune response. Sputum culture and AFB is very useful, but be careful in HIV patients because they can be negative. Now, over the last few years, we have a lot of nucleic acid amplification tests, NAATs, nucleic acid amplification tests for diagnosing TB. So the gene expert is one such test that the WHO recommends. And apart from you being able to do that in the sputum, very good. And HIV ayage meka hondai mokada HIV ayage chuti එකක් උනත් detect කරන්න පුළුවන්. But we use this in routine clinical practice quite a lot as well, because if you've worked in the wards, you've seen this test being sent off. Yes, post-primary, secondary TB means the same something. So gene expert test is a nucleic acid amplification test for Mycobacterium TB, good for diagnosis. You can use it on the sputum. But another useful importance of this test is that it can detect rifampicin resistance, right? That is another importance of this test. So the gene expert that can detect rifampicin resistance. There are more advanced nucleic acid amplification tests called line probe assays, which can detect both isoniazid and rifampicin resistance. Right? But the gene expert is mostly rifampicin resistance. Line probe assays you can do isoniazid and rifampicin resistance. So in addition to the diagnostic value of these gene expert tests, they also have a role in detecting resistance. Right. So these are your usual modes of diagnosing TB. Now a word about ADA, adenosine deaminase. Now adenosine deaminase, the role of that is in pleural TB, right? And it has a very good role in pleural TB. So as to say that this statistic is important, if you have a pleural effusion which is exudate and lymphocytic, so exudative lymphocytic pleural effusion with high ADA has almost 95% sensitivity and specificity for pleural TB. So the combination of a lymphocytic exudative effusion and a high ADA has almost 95% sensitivity specificity for TB diagnosis. So but we don't use ADA for any other thing, right? For example, you can't diagnose spinal TB and things with ADA. CSF ADA measurements are not useful. So it is a pleural fluid ADA that is what important. So make a varadi, ADA is very useful, and when coupled with a lymphocytic exudative effusion has almost 95% sensitivity specificity. The gold standard for diagnosing pleural TB is a pleural biopsy. If somebody asks in MCQ, the actual gold standard is a biopsy. We don't do biopsies at all or very rarely. Api godak lymphocytic effusion, high ADA, that is enough evidence for us to treat for pleural TB. So no, we don't use ADA in acidic. We can measure it, but it doesn't have any place in the diagnosis. Now, IGRAs or interferon gamma release assays are also similar to MANTU test. They just say, okay, you have had exposure to TB and you can mount an immune response to TB, right? And they are not diagnostic, right? So you do not use them for diagnosis. It just measures the interferon gamma response. And TB, you get a massive interferon gamma response on exposure. So if your immune system has been primed to TB, this will be high interferon gamma. So the gold standard currently for diagnosing post-primary TB is the AF culture and gene expert. Those are the two commonly used methods. So මේවා අපි discuss කරා. Right. Any questions about that? So this is all about latent tuberculosis, right? That just shows that you have a immune response to TB, and there is organism in the somewhere trapped inside you, right? That is what happens in TB. Tisura, you have a question?
Yes, sir. Sir, do we treat based on now in the ward? I have seen we do the MANTU or the IGRA, and then we start treatment while awaiting the diagnostic test. Is that standard?
No, that is not standard practice. Mehemai, if you think the clinical picture is very suggestive, and say for example the MANTU is ulcerating and very big, right? You might start treatment, but that's not recommended. Sometimes we do that, obviously with chest physicians input. But sometimes the clinical picture is very supportive, and you don't want to delay the diagnosis. If you have ulcerating, strongly positive MANTU, you can justify treatment. The other case is, say, if you have HIV, active HIV, right, with a low CD4 count, and then you have a TB suspicion with a positive MANTU. That again, you might prompt you to start treatment, because you expect the MANTU to be negative in HIV because the immune response is low, but it's such an overwhelming infection that it's getting some sort of response. So these are some instances where we might treat based on a MANTU. Yeah.
Right. And so if that's not the case, what's the sort of place for this MANTU in our setting?
So sometimes you do this. You want to check for sort of BCG vaccine response. Whether your BCG vaccine has mounted a response, might do a MANTU. Then other instances are, say we want to start on strong immunosuppressive medication like biologics, for example. එතකොට අපි IGRA කරනවා or MANTU කරනවා just to see if they have a significant latent TB. එතකොට you might give them a short course of treatment for that before starting them on that biologic, because if they have significant latent TB, ඕක පස් ගාලා ඇවිලෙනවා when you give the biologic. So those are some users of the IGRA or MANTU. Yeah. Especially yes. Biologics. In the setting of biologics තමයි අපි ගොඩක් වෙලාවට ඒක කරන්නේ. Okay. Then, so what is the most sensitive is definitely the nucleic acid amplification test. That is very sensitive for TB diagnosis. Right. A little bit about the BCG vaccine. So BCG, the important thing to remember is that BCG vaccine does not prevent you from getting pulmonary TB. Right. It prevents you from getting miliary tuberculosis. And some types of possibly extrapulmonary TB, but not pulmonary TB. Right? So no, get this out of your head. You might see this in the wards, but strongly positive MANTU does not diagnose active disease. It is only a suspicion. MANTU is not categorically not used for diagnosing TB. Right? You cannot say. Right? You can just argue or suspect it. Right? IGRA blood. IGRA karane blood. It's a blood sample.
Excuse me, sir.
Yes.
Setting of pulmonary TB, sir, if patients develop a pleural effusion, is a diagnostic aspiration always indicated, sir?
Yes, because if you want to treat it, you have to, sometimes you can get pleural TB and pulmonary TB at the same time. Yeah.
So in that sense, sir, do we still treat it as a pulmonary TB now, so not as an EPTB?
No. So pleural TB and pulmonary TB is mostly treated in the same way. There are some extrapulmonary TBs that you treat slightly differently. But pleural TB most of the time is 6 months. See, very similar. So, so gynae, because Gene Expert is a PCR based method, you can detect bacteria, dead bacteria also. Right? But if there is some bacteria there, you will detect it. Right? So it is sensitive, very sensitive. Right. Okay. Right. Now, I think the next MCQ is on treatment. Right. So here I have just given you the treatment strategies for TB. Right. Make a mangitane I langadi venaskara, but I don't think it has changed a lot. Yeah. Note එකේ තියෙන අලුත් මේක මම මේ slide එක මට ඒක update කරන්න අමතක වුණා, but I don't think there are small changes, especially in the sort of relapse treatment ඒ වගේ වල ඒව ඔයගොල්ලෝගෙන් වැඩි අහන්නේ නැහැ. හරි? And drug resistant treatment in the latest guidelines I think came out last year. හරි. දැන් මේව ඔක්කොම pharmacology just for your reference, right? We'll talk about some of these concepts as we go. Right. True or false regarding treatment for pulmonary TB? 9 months නෙවෙයි ඊටවත් නෑ. There are some indications for treating longer. However, right. මෙතන මම list එකක් දීලා නැහැ. But essentially, longer treatment අපි කරන්නේ for CNS TB definitely yes. We treat it for longer, right? Sometimes 9 months or 12 months for CNS TB. අනිත් එක සමහරවිට අපි long treatment කරන්නේ pericardial TB වලට. Sometimes we treat a bit longer. But even others, most of the other extrapulmonary ones, we treat for 6 months unless a chest physician advises otherwise. Right? CNS TB definitely is more than 6 months. We have 9-12 months treat කරනවා. Right. But for pulmonary TB, pleural TB, all of these are 6 months duration. Right. Then, right, side effects. Now, if you take isoniazid, which is a very commonly used drug in the intensive phase and the continuation phase of TB treatment, the main problem is hepatotoxicity, and also it can cause a peripheral neuropathy, right? Neuropathy එකක් එන්න පුළුවන්. So you have to give vitamin D supplementation to prevent them from getting the neuropathy. It also causes weird sort of rashes and sort of SLE-like syndrome එකක් වගේ එන්නත් පුළුවන්. Right? ඔය සමහරවිට මේ බලමාලු allergy තියෙන අයට they get reactions with isoniazid. Right? බලමාලු allergy. Right. So that is that. And the other common side effects you should know, rifampicin, all of you know that the color, changes in color of the urine. එනවා කියලා. Ethambutol, the main problem is the ocular toxicity. It causes optic neuritis. Right. Right. So ඒ වගේ side effects ටිකක් අහන්න පුළුවන් අපිට. So is it isoniazid causes peripheral neuropathy is true ළමයි. Pyrazinamide causes optic neuritis. Ethambutol වලට තමයි optic neuritis එන්නේ. Right. Now the main problem with rifampicin is that it can cause a lot of drug interactions because it causes liver enzyme induction. Right? So most of the HIV anti-TB regimes are have alternate drugs to rifampicin. Right? ගොඩාක් වෙලාවට use alternate drugs in HIV associated TB because ගොඩාක් කර rifampicin දුන්න ගමම it interferes with the metabolism of some of the HIV drugs. Right? So that is a bit of a dangerous situation. Right? So you have to be careful when you are treating it. And there are various other drugs which we use which are alternates to rifampicin. So important problems with rifampicin are the discoloration of the blood and body fluids, also with the also cause the induction of hepatic enzymes. Right. Streptomycin we used to use quite a lot. We still use it for CNS TB, and the main problem is like gentamicin, the same group, causes sort of hearing problems. So you have to be very, very careful when you are giving it. Right. Right. So a few questions. Samples can be said about TB PCR. Sputum, yes. CSF වල කරාට වැඩක් නෑ ගොඩක් වෙලාවට මිනිස්සු කරනවා තේරුමනේ. Sputum is the recommended sample. මේවා. In other places like ascites, pleural fluid, the yield of this PCR is very low. So we don't waste time. Right? Essential nෑ sputum යවන්න, but it's better if you can send it. Right? You can use culture and AFB stain to diagnose pulmonary TB, but if you can, you send the sputum for PCR as well. Right? Can extrapulmonary TB patients become infectious? Usually not. Usually not. Sorry. Sorry. Okay. Now, this MCQ is also focusing on the treatment. Right. So, treatment again, we have the treatment differs if there are new cases or relapses or treatment failures. relapses treatment phase, ඒව ගැන ඔයගොල්ලෝගෙන් අහන්නේ නැහැ because that's complicated. The only thing we will ask you is about the new cases. ඔකට අපි මේ category 1 කියලා කියනවා සමහර වෙලාවට. Right. So all of you know there is an intensive phase and a continuation phase. So you know the regimes. නේද? ඒක මෙතන තියෙනවා. So HRZD for 2 months in the intensive phase, and then the continuation phase will be HR for 4 months. Sorry, isoniazid rifampicin for 4 months. Right. So 6 months is the usual time period. Right. So the intensive phase is 4 months. It is 2 months. Right. Patient isolate karanna ඕනද? So ADAS, it is just the pleural fluid that we do. No point in sending anything else. Hari. So patient isolate karanna ඕනද? Sputum AFB become negative වෙනකම්. Now that is a bit of a controversial thing. ඔක ලංකාවේ නම් කරනවා. හැබැයි සාමාන්‍යයෙන් anti-TB පටන් අරන් සති දෙකක් විතර ඇතුළත the infectivity goes down dramatically. So you don't have to check and see AFB negative වෙනකන් isolate කරන්න ඕනේ නැහැ. ලංකාවේ සමහරට ඔක් කරනවා. But strictly there is no need to do that. හරි? Okay. Right. Now I'll talk about the third one in a second, but I've already told you that there are certain types of TB that you treat for longer, like TB meningitis and pericardial TB. Right. හරි. ඔතන තව පොඩි concept එකක් තියෙන ඔයගොල්ලෝ මතක තියාගන්න. In some cases we also give steroids to patients with TB. මෙතන මේ යට මේක list එකක් තියෙනවා. ඒ ටික පොඩ්ඩක් බලා ගන්න. So whenever there is excessive inflammation which can cause obstruction, like say in TB meningitis you can get obstruction and hydrocephalus, right? When we talk about cardiovascular medicine, we talked about pericarditis, chronic pericarditis, constrictive pericarditis. Then urinary obstruction in genitourinary TB, laryngeal TB, right? There's cord compression in spinal TB. These instances, we add on steroids to the treatment regime, right? Steroids, and that is to reduce this excessive inflammation. Right? Excessive inflammation එක අඩු කරන්න අපි දෙනවා. Right. Okay. Right. So that's just about the treatment of TB. කොහොමද ඒක treat කරන්නේ කියලා. Right. Right. Occasionally, so in our setting, we give streptomycin in CNS TB තමයි ගොඩාක් වෙලාවට පාවිච්චි කරන්නේ, right? Or in children because ethambutol is contraindicated. සඳුනි dead bacilli හිටියයි කියලා positive මාන්ටු ඒකත් ලොකු සම්බන්ධයක් නැහැ. Remember the මාන්ටු is just indicating that you can mount a reaction against an injection of the TB නෙවෙයි එතන ගහන්නේ but antigen එක. අපි හැමකට ගැහුවම you can mount a response. There is nothing to do with dead bacilli මාන්ටු. හරි. හරි. So මෙතන මේ round කරන හරියේ, right? When somebody is exposed to tuberculosis, you might give them prophylactic treatment, right? එතකොට මේ තුනක් indications තියෙනවා, right? That are definite indications for chemoprophylaxis. PLHIV කියන්නේ people living with HIV. That's how you refer to patients with HIV now. People living with HIV. Right? So children less than 5 who are close contacts, you need to give them prophylaxis, right? Or people with HIV, living with HIV who have come in contact with somebody with a spear positive TB. So there are indications for you to give prophylactic. Whatever prophylactic anti-TB then in there, right? So there are some people where you give prophylactic anti-TB, especially children less than 5 years and also people living with HIV when they are exposed to TB. Right. Right. හරි මේ MDR TB ගැන තියෙන MCQ එක කපා ගන්න ඒක වැඩි ඔයගොල්ලන්ට. If you are really interested on the drugs that we give, මෙන්න මෙතන ලයිස්තුවක් තියෙනවා. ඒක නිකන් කියව ගන්න but අහන්නේ නැහැ ඔයගොල්ලෝගෙන් ඒක බය වෙන්න එපා. හරි. Drug resistant TB ගැන අහන්නේ නැහැ. It's very complicated. But you can see things like levofloxacin are used. That is actually the reason why we hesitate a lot to start levofloxacin for pneumonia. If you go to some other countries, if you take their guidelines, levofloxacin is a first-line drug for community-acquired pneumonia. Sorry, America. But Sri Lanka, we do not prescribe levofloxacin at all because of the risk of the TB drug resistant emerge වෙන්න පුළුවන් නිසා we use it very, very sparingly. Right? So because it's used to treat drug resistant TB. Hi. Ciprofloxacin, again it has an anti-TB action. අපි වැඩි ciprofloxacin pneumonia වලට දෙන්නේ නැහැ, it's mostly urinary නේ. ඒක ලොකු ප්‍රශ්නයක් නේ. So the drug we use for prophylactic is isoniazid. Right? Hi. Any questions about TB treatment and diagnosis? So there were plenty of questions about MAN2. MAN2 is not a diagnostic test for TB. Right? Treatment, what we will ask is only the sort of category 1 or new case treatment. It's right. We won't ask about relapse treatment. Don't worry. So bone and spinal TB again, Supun, 6 to 9 months, right? Most of the time we end up treating for 9 months with a spinal TB. Again, there is no guideline to this. There is no way of monitoring progress. Now, so sometimes you can get lymph node TB. Lymph node TB, it is a common thing to say that we don't usually do FNAC because the problem is if you do FNAC, you can get a tracking of the organism along the tract and can spread to the skin. Samate FNAC කරන්නේ නැහැ. අපි සමහරවිට අර resection biopsy, excision biopsy එකක් තමයි කරන්නේ. And lymph node TB is treated in the same way as extrapulmonary TB. It is a type of extrapulmonary TB. Right. Okay, but we don't FNAC or needles, we just take the node out as a whole. Hari. Now this question, even though I have put it slightly advanced for you, it is sort of what you do when you have anti-TB induced liver problems. මෙතන මේකක් guide එකක් චුරේ දීලා මම ඒකේ principle එක විතරක් කියන්නේ, don't worry about the MCQ. මෙච්චරයි. When you have anti-TB induced hepatitis, the first thing is to stop everything. ඔක්කොම නවත්තනවා. හරි, ඔක්කොම නවත්තනවා. ගොඩක් වෙලාට එහෙම තමයි කරන්නේ. ඔක්කොම නවත්තලා then you gradually reintroduce the anti-TB. හරි. Gradually reintroduce anti-TB as shown in this figure. මෙන්න මෙතන පල්ලෙහා තියෙන විදිහට gradually මේවා කරනවා. හැබැයි in patients who have smear positive pulmonary TB or those who have severe organ involved, like CNS TB is a very good example for this. So the disease is very severe and life-threatening. Or they have smear positive pulmonary TB. ඕක නවත්තන්න නැතුව we give something called a bridging regime. සම්පූර්ණ ඔක්කොම wholesale එකේ නවත්තන්න නැතුව we give a bridging regime. Right? Usually this consists of ethambutol and streptomycin. So the bridging regime එක දීලා when the liver functions come back to normal, we then gradually reintroduce the other anti-TB drugs. Right? And if the liver goes back again, what alternate regimes So only thing you need to know, most cases when you have anti-TB induced liver function, and you gradually reintroduce the drugs one by one. But in some instances like smear positive pulmonary TB or CNS TB, you can't suddenly stop because they have life-threatening disease. Then you have to give them a bridging regime with ethambutol, streptomycin, ගොඩාක් වෙලාවට. And then once the liver functions normalize, you restart the anti-TB one by one. හරි. ඒක පොඩ්ඩක් උඩ සැර වැඩි, but just for your information එහෙම තමයි කරන්නේ. හරි. Any questions about these ones? TB treatment ගැන? So I've given you a comprehensive discussion about all the sort of things we can ask about TB. There's a SCQ on TB also. ඒකත් උත්තර ලියන්න. TB විතරක් නෙවෙයි මේක. මේක මේ DD එකක් අහනවා. I think ඒක කරන්න. Answers are here, roughly answers, but you write. ලියන්න අපි discuss some of these at the end, closer to the exam. All right. Right. So there are some questions about TB. COPD. Is there a TB? So lymph node, in lymphoma, again, lymphoma is a very funny disease. Clinically, it is very difficult to differentiate from TB sometimes. And also, even from the lymph node distribution, you can't, right? Unless it's something like Hodgkin's lymphoma, which is a very nice sort of above diaphragm, neck, chest involvement. Right? So it's very difficult to differentiate. COPD වල DLCO එක අඩු වෙනවා කියලා අපි කියමු emphysema නිසා. And what happens is all the residual volumes go up because of hyperinflation. Residual volumes and lung capacity goes up because of hyperinflation. Any other questions?
Sir, again in COPD, COPD poorly responds to bronchodilators. What about that statement? Is it correct or?
Poorly response කියන එක ටිකක් diffuse statement එකක් නේද? Poorly respond කියන ඒක එච්චරම හොඳ මේක නෙවෙයි. They do respond. නිසා you can't say that's true නේද? Poorly respond කියන එක වැරදි කියලා තමයි ගන්න වෙන්නේ. Of course, you won't see that complete airway reversibility like you see in asthma, but it does respond to bronchitis. මොනවටද දෙන්නේ නේද? So yes. Okay, so thank you. Yeah, so duration of treatment for all types of TB Vishwa is 6 months, except possibly for CNS TB and pericardial TB, or any other types of TB which the chest physician might say to give longer. Right? Most of the time it is 6 months, except in CNS TB and pericardial TB. Right? තව very specific ඒවා තියෙනවා ඒවා ඔයගොල්ලෝගෙන් අහන්නේ. මොකද්ද මේ තව අහන්නේ පහළ තියෙන්නේ මොකද්ද? Pulmonary TB, can they also? Yes, pulmonary TB they can get cervical lymphadenopathy, especially where scalene node කියලා එකක් තියෙනවා enlarge වෙන්න පුළුවන්. Anterior scalene node කියලා එකක් තියෙනවා.
Sir.
Oh, Tanu.
Sir, there's an MCQ in 2012
yes.
saying regarding pneumonia. The treatment with ciprofloxacin delay the diagnosis of tuberculosis.
මොකද අය කියන්නේ?
Treatment with ciprofloxacin delay the diagnosis of tuberculosis. Is it true?
Treatment with ciprofloxacin delays the diagnosis of TB. එහෙමද කියන්නේ?
Yes. Yeah.
Theoretically possible because ciprofloxacin with anti-TB action එකක් තියෙනවනේ. ඒතකොට කියන්නේ ඒකෙන් පාගෙට treat කරලාදී diagnose කරන්න අමාරු වෙනවා.
Okay, so thank you.
Right. So somebody's asking, is there reason to give anti-TB for more than 6 months? Pleural TB, usually not unless there is a big sort of pleural thickening and lung restriction. Very rare. Samani pleural TB 6 months. Right. It's very rare to give it longer. Right.
Sir, rusty sputum මොකේද සාමාන්‍යයෙන්
ඒක විශේෂයක් නෑ නියුමෝනියා වලින්වත් පුළුවන්. නියුමෝනියා වලින්වත් පුළුවන්. TB වලින්වත් පුළුවන්. එහෙම විශේෂයක් නෑ.
Sir, organism කෙනෙක්ට එහෙම specific
නෑ. I don't think so. No.
Okay.
චමත් සෙනසුරාදා පුළුවන්ද?
පුළුවන් සර්.
හරි. සෙනසුරාදා